you. Thank you, thank you, and thank you for that lovely introduction, Zoe. Welcome. Welcome, family. Woo! Friends. Students. Jefferson faculty. Woo! International colleagues and collaborators. Woo! And collaborators, everyone. It's a privilege to be delivering the Eleanor Clarke Slagle Lectureship in my home city of Philadelphia. With my university just 4 blocks away. Philadelphia is a great city. I'm sure you've had a chance to experience it. How many Philly people do we have here? Let's see a show of hands. Well, Philly people, let's show our guests. Let's give our guests a crash course in fitting in Philly, shall we? Especially after the Eagles won the Super Bowl this year. If you're at Wawa, our favorite convenience store, and someone holds the door open for you, you say, "Go Birds!" If you're standing in line in a session and somebody says, "Please, go in front of me," you say, "Go Birds!" But if you're driving in on the Schuylkill Expressway and somebody cuts in front of you, then you say, "Fly, Eagles, fly, on the road to victory. E-A-G-L-E-S, Eagles!" Obviously, we're still basking in the glory of the Eagles winning the Super Bowl this year. But Philly's more than just about sports. We are the city of sisterly love, brotherly love, all gender and diversity love. We're the birthplace of freedom and equal rights, and we're working hard to keep it that way. We're the mural arts capital of the world. Go figure. I hope you get a chance to go out and see some of them. They're just lovely. This is one of my favorites. And we're home to 2 of life's greatest delicacies, soft pretzels and cheesesteaks. I hope you have had a chance to try them. Oh, and let's not forget Rocky, the ultimate underdog story. Do go to the art museum, run up the steps, throw your arms up in the air, and jump up. That's what we do here in Philly. Philly also has its own lingo. We say things like, "Yo, can I get a hoagie and a bottle of water?" That's W-O-O-D-E-R. Try it with me. Water. Look at you guys. You're fitting in already. So now that we've established that I'm so happy you're here and that Philly is great, let's turn our attention to the topic of today's presentation. Today, I will introduce you to the concept of precision occupational therapy, a systematic process to guide your work and measure its impact. I hope to inspire you to use these concepts in your clinical practice to create evidence and expand the value and reach of occupational therapy. And secretly, in the next 40 minutes, I hope my family and friends will finally understand what I do and why I love it. So, yo, everybody, get a sip of water and let's begin. Next slide. Occupational therapy, where science, compassion, inclusion, and creativity collide. A therapeutic process that can change the lives of our clients. Clients who are diverse in their diagnoses, racial, ethnic, and cultural backgrounds, and who lead complex lives. With this diversity comes the richness of occupational therapy, a profession that addresses the whole person as an individual in the context of their natural environments. Consider Sophie, a delightful and social 5-year-old who is struggling in school and developing a negative self-image. Or Jalen, a 26-year-old facing substance abuse disorder and mental health challenges, and is currently living on the street. Or Maria, an 80-year-old experiencing chronic pain and fatigue from an autoimmune disease. She values living independently, but is struggling to do so. Each of these persons brings unique, personal, and contextual factors that impact their lives. Occupational therapy works because we consider each person's uniqueness and complexity and meet them where they are to foster their ability to participate in wanted, valued, and needed activities and occupations. But how do we show our effectiveness? How do we capture the complexity of OT and communicate with others about what we do and why? Precision occupational therapy is needed to guide our work. I'm using the word precision because it embodies our unique skills as occupational therapists who respect individuals' unique strengths and needs and individualize interventions to enhance wellness, participation, and quality of life. A precise, individually tailored approach is our strength. I borrowed ideas from an emerging concept in healthcare, precision medicine. Precision medicine takes a personalized approach. Rather than traditional medicine where one treatment fits all, precision medicine uses data about a person's unique genotype and phenotype combined with evidence and theory to make precise treatment recommendations. Precision medicine respects the individual. It considers multiple streams of information simultaneously and designs a treatment that is specifically tailored to the individual. Could we apply these concepts to occupational therapy in an explicit way? Could we gather information from multiple sources to understand our clients' experiences and craft occupational therapy interventions that focus on each individual's participation in occupations? I argue we are already doing this, right? But we must package it in a systematic way that can be easily articulated, utilized in everyday practice, studied, replicated, and evaluated. Okay, let's begin with a story that can serve as a roadmap for applying precision occupational therapy in your practice. I'll use my life's work in sensory integration to tell this story and show the power of precision occupational therapy. I've been fortunate to be part of a team whose work led to occupational therapy using air sensory integration finally being recognized as an evidence-based intervention. This happened because of a clear, systematic, individualized process guided by occupation. That's precision occupational therapy. You'll quickly see how this process applies to every occupational therapy practice and setting. You'll see how our story improved clinical reasoning, expanded access to occupational therapy for autistic individuals, and engaged scientists outside of the profession to study and work with us. Your journey can do the same. Our story started in 2012 when the American Occupational Therapy Association reached out about a situation. The Department of Health and Education in a particular state decided that occupational therapy using the principles of sensory integration was no longer allowed to be used in their school districts. They concluded that there is insufficient evidence, scientific and medical evidence, to show that it was a reliable or effective form of treatment that leads to improvements in a person's ability to function. The state based this ruling on a particular case, a youngster who had been receiving school-based occupational therapy for several years. AOTA asked a group of us to review the case and craft a rebuttal. In fact, when we reviewed the case, we found wonderful anecdotal evidence of the positive effects of occupational therapy using sensory integration on this youngster's home and school life. But we found no data, no documentation of the gains this youngster had made, no rationale for the chosen treatment, and scant assessment data to guide treatment choices. Yikes. By the way, this is fear and anxiety from the Disney Pixar movie Inside Out 2. Great movie. It's a movie about emotions, emotions we all feel, especially when we're forging territory that can be filled with obstacles and criticism. These characters will help illustrate the many challenges we may face as a profession when questioned about why we do, what we do, why we do it, and the evidence to support it. I wondered, is this story of long-term occupational therapy with minimal documentation of outcomes a familiar story? Was this happening in all areas of OT practice? Well, I discovered it was, and it made me sad and a little embarrassed. In my work and interactions with therapists around the world, in all areas of practice, I found therapists who were passionate about their work and believed that their interventions make a difference. But they often lacked data. They were not able to identify the rationale for the chosen treatment approach. They did not have adequate assessment data to guide treatment. They did not link their treatment to occupation, and they failed to measure outcomes that were meaningful and occupation-based. Would occupational therapy survive in a world of benchmarks and evidence-based practice? Well, serendipitously, about the same time, I was invited by a team of master clinicians at Children's Specialized Hospital to speak at their grand rounds about occupational therapy using air sensory integration. These therapists wanted to study it because they saw its positive impact on their clients, but they were being challenged by their administration to show the evidence. Hope emerged. Just about that time, the Autism Speaks Foundation published a request for applications, and it specifically tailored sensory interventions for autistic persons. Their main stakeholder group, parents of autistic persons, were asking for guidance on this issue. They were asking for guidance because their children were experiencing challenges in everyday activities, such as eating, dressing, playing, sleeping, learning, the things we do related to their sensory challenges. In fact, over 80% of autistic persons have challenges in sensory integration that impact their function and participation. These parents were seeking occupational therapy, one of the top requested and utilized autism interventions to address these. But their schools and insurance companies were often not supporting it due to perceived lack of evidence. So we said, yo, let's do this. We wrote a grant, a randomized control trial of occupational therapy using air sensory integration for autistic children, and our project was chosen for funding. But quickly, hope and joy shifted to worry and anxiety. We recognized that this study needed to be carefully crafted with high attention to scientific rigor. We needed to capture the complexity of occupational therapy in a systematic way and evaluate its effectiveness. Fortunately, we already had many of the foundational elements in place. We had comprehensive and validated measures of sensory functions that link to occupations, thanks to the works of Doctors Zoe Mayu, Suzanne Smith-Rowley, Diane Parham, and their international team. Thank you. They continue to work and forward the development of these testing measures. We had a way to measure treatment fidelity to assure that the intervention was delivered in keeping with its theoretical principles and practices. Thank you to Drs. Ellen Cohn and Lucy Miller for initiating this, and Drs. Parham and May Benson for leading the development and testing of this fidelity measure. We had relevant, meaningful outcome measures of participation in occupation, thanks to the work of many occupational therapy measurement scientists. But we needed to manualize the intervention so that it could serve as a blueprint for practice and be replicated by other scientists. Dr. Mayu and I and the team at Children's Specialized and Thomas Jefferson University manualized the intervention into a guidebook titled A Clinician's Guide for Implementing AIR Sensory Integration, Promoting Participation for Children with Autism. Importantly, this guide operationalizes AIR sensory integration, individually tailors the occupational therapy practice, the occupational therapy process, seats practice in occupation, uses theory and assessment data to guide intervention, details the active ingredients of the intervention, and measures outcomes at the participation in occupation level. We package this in a process called data-driven decision-making. Data-driven decision-making is a guide for precision occupational therapy. It guides the clinician's reasoning, ensuring they are occupation-based, theory-driven, data-based, and outcomes-oriented. Some aspects of this idea first appeared in the OT literature in 1996 when Clarke and Linda Miller outlined ideas about progress monitoring for school-based practice. And in 2015, when Drs. Bissell and Cermak elaborated on the importance of measuring outcomes in practice. Later, others, such as Behrens and colleagues, proposed evidence-based decision-making processes in the literature. And certainly, our colleagues who study clinical reasoning, such as Dr. Schell, Mattingly, Fleming, Lawler, and Cohn, to name a few, have touched on many of the concepts included in precision occupational therapy. We built substantially on these ideas in data-driven decision-making and packaged them into a usable guide. Let's unpack data-driven decision-making a bit more. In data-driven decision-making, first, seat your practice and occupation by identifying the reasons that your client is seeking occupational therapy. Identify strengths and participation challenges via the occupational profile. Like Sophie, who brings strengths, her social nature and interest in learning, with participation challenges, difficulty using her hands to manage crayons and materials and other learning materials. Next, we identify an appropriate theoretical framework to guide practice. Choose the theory based on the client and contextual factors. Ask yourself, what theory will best help guide your work with each client? With these pieces in place, choose assessment measures that align with your chosen theory, and conduct a systematic assessment to identify the specific factors impacting participation. Assessment data is then analyzed and used to generate hypotheses, a pivotal step in data-driven decision-making. Next, work with your client to create goals and identify outcome measures to evaluate change. Turning our attention to intervention, we set the stage for intervention by identifying the setting, the approach, for example, direct, consultative, group, telehealth, and the dosage that best matches the context and the client's needs. We are now ready to conduct the intervention, and this can include direct intervention with the client, environmental adaptations or supports, and/or work on tasks, activities, and occupations. Finally, we measure outcomes to monitor our progress. This is the blueprint for precision occupational therapy. Of course, these steps are dynamic. For example, you may need to go back and revise your hypotheses or rethink the intervention based on your client's response to treatment. But I think you get the idea of how data-driven decision-making can guide your clinical reasoning to create precision occupational therapy. I want to pause and highlight a couple of points about data-driven decision-making. First, hypothesis generation and testing. To create hypotheses, first, identify the factors impacting occupational participation via assessment. Next, link these data with the participation challenges via hypothesis statements. The hypotheses will guide treatment. Finally, test. The hypotheses are tested by measuring outcomes. I think you can appreciate how the concept of hypothesis generation helps tailor and define the intervention. Now let's examine outcome measurement in a bit more depth. Another important aspect of precision occupational therapy using data-driven decision-making is outcome measurement. Outcomes are measured at the proximal and distal levels. Proximal outcomes are those underlying factors impacting participation in occupations, and distal outcomes are the occupations themselves. This then links the intervention to occupation. Let's revisit Sophie, Jalen, and Maria and see how hypotheses are generated and outcomes are measured. I have simplified these examples to illustrate the use of data-driven decision-making for precision occupational therapy. I recognize our clients are complex and that there may be more than one hypothesis or outcome for a given participation challenge. But these simplified examples, I hope, will help you get the concepts of hypothesis generation and outcome measurement and apply them and begin to think about them, using them in your practice to address the real-life issues our clients face. Sophie, she's social and enjoys learning, but she's having difficulty participating in learning activities in her kindergarten classroom because she's struggling to manage crayons and other materials. There are potentially several factors impacting this challenge. Sophie's history and occupational profile guide us to focus on the sensory motor aspects, and we choose AIR sensory integration theory to guide assessment and intervention. The assessment data show that Sophie has less than expected ability to discriminate and perceive tactile and proprioceptive or position sense information and cues, which affects her ability to plan and execute actions with her hands. We craft a hypothesis that links the assessment data to the participation challenge. Decreased tactile and proprioceptive perception needed to effectively guide actions are impacting her ability to use her hands to participate in learning activities. Hypothesis generation also serves as a guide for outcome measurement. That is, what do we expect to change based on the intervention? For Sophie, the change or the distal outcome is improved use of crayons for participation in learning activities. This can be measured in a variety of ways, but we choose goal attainment scaling and charting of observational data. The proximal factors that will impact change are improved scores on measures of tactile and proprioceptive perception and praxis, or the ability to plan and execute movement. Of course, it's more nuanced than this, but I think you get the basic idea. Generate hypotheses based on assessment data, and then identify outcomes that will gauge the effectiveness of the intervention. And precision occupational therapy can be used in all areas of practice. Let's take Jalen, a young woman who is currently unhoused and experiencing mental health challenges related to her diagnosis of schizophrenia and generalized anxiety. Assessment data show that Jalen enjoys cooking and previously worked in a kitchen. Assessment data also revealed that lack of access to nutritious meals and sleep deprivation due to sleeping in a crowded and often noisy shelter environment are key factors impacting her mental health and well-being. The hypothesis then is that lack of access to healthy foods and poor sleep patterns are impacting Jalen's mental and physical health. The distal outcome is improved mental and behavioral health measured by participation in cooking activities and perceived self-esteem. And the proximal outcomes are eating one balanced meal per day and consistent use of client-centered resources and strategies for better sleep. These can be measured with standardized outcome measures and staff-reported data. And finally, Maria, an older adult with chronic pain and fatigue, who values living at home but is unsafe to do so. She's experienced several falls and was admitted to the hospital twice in the past 3 months. Assessment data show that Maria loves to host Card Club, but she's struggling to do so because of fatigue and safety challenges. Her home is filled with many meaningful objects, such as her Yadro collection and folding tables and chairs for Card Club. She also has a variety of assistive devices laying around to help with walking, carrying, and reaching for daily tasks and activities. Maria is weak and fatigues easily, and her environment is creating many potential safety hazards. While respecting Maria's culture and building on her interest and strengths, we can identify several hypotheses to create a precision occupational therapy approach. Here, I will focus on 2. Maria's busy environment creates a risk for falls that make it difficult for her to live at home safely. And secondly, Maria's weakness and fatigue impact her successful participation in wanted and valued activities. Accordingly, outcome measures for Maria are, distal outcomes for Maria are, that she will remain in her home safely and without need for hospital admission, and that she can participate in Card Club once weekly for an hour. Proximal outcomes are improved strength, endurance, and decreased falls. Now let's turn our attention to intervention. In data-driven decision-making, the hypothesis helps specify the intervention. The rehabilitation treatment specification system can be used to further guide the clinician's clinical reasoning for intervention. It helps characterize treatment by describing the targets of the intervention, the proposed mechanisms of action, and the active ingredients of the intervention. As Hart and colleagues state, treatment must be specified and measured with precision to link the improvements in function, and I might add occupation, to the intervention. Here you can see how the rehabilitation treatment specification system can guide the clinical reasoning to specify the intervention via identification of the intervention targets or the aspects of function expected to change, the proposed mechanisms of action or how the treatment is expected to work, and the active ingredients of the intervention or what the clinician does. This specifies the intervention, and as the treatment is specified, the causal factors can be clarified and measured, and clinicians can better describe what they are doing and why with greater precision. Detailing and describing intervention requires sophisticated clinical reasoning so that it is precise and individualized. Here you see an example of clinical reasoning in AIR's sensory integration. The sensory integration pattern identified in the assessment data is at the top in blue, vestibular bilateral integration. The principles of AIR's sensory integration are in green on the sides, and the activities are in the middle in yellow, with options for upgrading or downgrading the activity to target the just right challenge for this particular child. In the words of the research treatment specification system, we described the what of intervention, and we personalized it based on the client's needs and responses. Now let's take a look at how interventions are crafted using precision occupational therapy. Returning to Sophie, based on our hypotheses, treatment will be directed toward improving tactile and proprioceptive awareness and praxis so that she can use her hands effectively during learning activities. The proposed mechanisms of action are change in sensory perception via neuroplasticity, and the active ingredients of the intervention are individually tailored sensory motor activities contextualized in play at the just right challenge, rich in tactile and proprioceptive sensation to promote the use of her hands for learning activities. These are the active ingredients of our chosen theoretical framework, AIR's sensory integration. Thus, we have specified or detailed the intervention in a way that is theoretically driven, using the active ingredients and mechanisms of action of this theory, which are directed towards specific targeted outcomes. It might look like play as we go on a treasure hunt in a ball pit with Sophie and then play a game using crayons to circle pictures of the treasure she found. But sophisticated clinical reasoning underlies this process. For Jalen, who is experiencing mental health and wellness challenges due to lack of access to nutritious foods, inadequate sleep, and housing insecurity, we need to consider the many issues that may be impacting her mental health. Research suggests that engagement in meaningful activities and work foster health outcomes with those with mental illness. Given her past interest and strengths in cooking, we use learn by doing and task adaptation mechanisms of action to collaborate with Jalen and the staff at the shelter and engage her in planning and preparing realistic and affordable meals. We also work with Jalen to identify sleep preparation strategies that will help her sleep, things like an eye mask, earplugs, and a familiar blanket to foster longer periods of rest and sleep in the shelter. Again, sophisticated clinical reasoning, grounded in theory and evidence, are guiding intervention. And finally, Maria. Evidence supports the use of thoughtful and acceptable environmental modifications to improve safety and reduce falls. Evidence shows that participation in meaningful physical activities reduces fatigue and improves strength. Thus, we work with Maria to identify environmental adaptations to ensure safety and participation in valued activities while retaining objects that hold meaning for her. To reduce fatigue and improve strength, we work with Maria, who indicates she formerly enjoyed yoga and that she's interested in trying a TV-based yoga class at her home. While respecting Maria's culture and values, we co-created a useful occupational therapy intervention. Of course, our clients are more complex and nuanced, but I think you're getting the idea. Precision occupational therapy is evidence-based, data-driven, individualized, and occupation-oriented. So we did it. We detailed a systematic, individualized process to tailor and implement intervention and measure outcomes at the participation and occupation levels. And it can be used to guide practice and research. Now let's see how the use of precision occupational therapy in air sensory integration established its evidence base and broadened the impact of occupational therapy. Again, I will use my practice area to exemplify and ask that you draw parallels to your own. I'm going to pause for a drink of water. With precision occupational therapy in place, we designed a randomized control trial following the guidelines for clinical trial protocols, using rigorous characterization measures, blinded evaluators, careful evaluation, standardized outcome measures, timely post-testing, and intent-to-treat analyses. And we found that it worked. The children receiving occupational therapy in air sensory integration, shown in red here, performed significantly better on their distal outcomes measured by individualized goals. Note the p-value of 0.003 and the effect size of 1.2, indicating high significance and large effect. We also found that the treatment group improved significantly over the controls in independence in self-care and socialization on the Pediatric Evaluation of Disabilities Inventory, or the PD, a validated outcome measure. Also with strong p-values and effect sizes. These findings show that the goal attainment scale data are supported by the PD data and linked to improvements in function and occupation. Oh, thank you. Thank you. And we published this study in the Journal of Autism and Developmental Disorders, one of the most highly regarded autism journals. And it was listed as one of the most downloaded articles in 2015. Thank you. Obviously, there was great interest in this topic. And as it turns out, this study tipped the scales for showing that occupational therapy using air sensory integration for children with autism, and it was rated as an evidence-based intervention in the highly regarded Frank Porter Graham Institute publication for evidence-based practices in autism. And it also met the criteria for an evidence-based intervention by the Council for Exceptional Children and several other evidence-based guidelines. So we had evidence. We now have evidence that occupational therapy using air sensory integration improves participation in daily living activities and independence in socialization for children with autism. Next, replication and implementation trials emerged. You see, once you have the evidence and can describe what you do with precision, people notice. Clinicians use it in practice, and researchers conduct studies to further support or refute the evidence. The first thing that happened was that we partnered with scientists studying brain-based multisensory integration in autism. We were funded by the National Institutes of Health to compare two autism interventions, occupational therapy using air sensory integration and applied behavioral analysis, or ABA. We found that both interventions resulted in significant improvements in individualized goals over the no treatment group. Further, both treatment groups improved daily living skills measured by the PD. Now we have evidence that occupational therapy using air sensory integration is as effective as behavioral intervention in achieving individualized goals and participation in self-care activities and socialization for autistic children. If you're familiar with autism, you know that applied behavioral analysis, our comparison intervention, is the standard of care for autism, and that lots of dollars are allocated toward this treatment. Our findings then have the potential to shift some of those funds toward occupational therapy. Replication trials were conducted all over the world. Here you can see some of these, including Dr. Claudia Omari and colleagues in Brazil, Dr. Elizabeth Rendell and colleagues in the UK, and Dr. Phoebe Chan and colleagues in Hong Kong. All found that children in the occupational therapy using air sensory integration group improved over the controls in individualized goals. And another important publication emerged regarding the long-term impact of this intervention, showing statistically significant improvements in individualized goals at post-intervention that were sustained for 6 to 12 months follow-up. They also showed, yeah, good for them. They also showed that parents valued this intervention, stating a positive impact on their child's and their family life. As you may know, caregiver or patient-reported outcomes such as these are emerging as an important marker of clinically meaningful change. Now, several implementation trials are underway to extend this intervention to other settings and populations. We turned our attention toward improving access to this intervention for underserved and minoritized communities. We adapted the intervention for Black and African American families of autistic children based on their input and feedback to assure its cultural relevance, acceptance, and satisfaction. We created a telehealth adaptation and studied its feasibility so that rural and other underserved communities could have access to this intervention. And we created and studied an early intervention adaptation to extend this intervention to younger children. And now we are funded by the Patient-Centered Outcomes Research Institute, or PCORI, to extend this intervention to Hispanic and Latino families with autistic children. A shout out A special shout out to Dr. Lady Rios Vega and Rachel Dumont, who turned our attention to addressing the needs of minoritized groups so that they have better access to our services. And I'm really excited to share that implementation in schools is happening. We're building on the works of Dr. Colleen Whiting and Sarah Schoen, who showed that occupational therapy using sensory integration improved functional regulation and active participation in school activities, and that teachers and students valued this intervention. We know this work is important and valued based on the findings from Dr. Sarace McCune and Drs. Ify Lowry, who showed that occupational therapists, teachers, and administrators believe this intervention is useful and appropriate in schools. Now we are working with Drs. Whiting, Schoen, and a team of early career researchers and clinicians to extend this work by creating guidelines and resources for its implementation in schools so that we can study its outcomes. And precision occupational therapy using data-driven decision-making is reaching beyond sensory integration. It's being taught in academia and used as a guide for clinical training. For example, Drs. Andelin, Peterson, and Albright found that data-driven decision-making supports evidence-based practice for occupational therapy students at their universities. A team from Brazil found that data-driven decision-making offers a tangible approach to supporting practicing occupational therapy's clinical reasoning to guide client-centered assessment and report outcomes. And finally, my colleagues at Jefferson, led by Drs. Amy Carroll and Adel Hergy, showed that data-driven decision-making serves as an effective model for training students in level two fieldwork to implement evidence and data-driven approaches in clinical practice. And there are many other applications that have been presented at this conference as well. I'm just so pleased to see them all. So this story has a joyful ending. And who doesn't love that? Our original challenge to determine if there was evidence for the use of occupational therapy using sensory integration led to the development of precision occupational therapy using data-driven decision-making and resulted in this intervention being rated as an evidence-based intervention for autistic children. This recognition meant that other scientists wanted to collaborate with us, that many insurance companies are now covering its cost, schools are realizing its values, clinicians can describe and document what they do with greater precision, and more children and families have access. Importantly, occupational therapy has taken a prominent seat at the table in autism interventions. That's the clap. Now, back to your practice. As you have seen, data-driven decision-making guides precision occupational therapy, and precision occupational therapy is a roadmap for practice. By systematically detailing, describing, and measuring what we do as occupational therapists, we create and document evidence, garner respect, foster collaborations, and improve access. I invite you to use precision therapy in your practice. Seat your practice in occupation. Use theory to guide your practice. Conduct comprehensive, rigorous assessments and analyze your assessment data in light of your client's occupational challenges. Create hypotheses that link the factors identified to occupational needs. Co-develop goals. Identify how you will measure outcomes. Design interventions that are data-driven and theoretically based. And finally, measure outcomes. In other words, use precision occupational therapy. When you do, we can help individuals like Sophie, Jalen, and Maria realize our profession's vision of enriching lives for all individuals and society through meaningful engagement in everyday activities. Take this with you into your practice. This is our path forward. Thank you. Wait, one more thing, one more. I want to end with an acknowledgement to the many people who contributed to this story. Together, we can do so much. First, a special shout out to my mentors, Dr. Ruth Shem, I think is here somewhere, Laura Gitlin, Lucy Miller, Janice Burke, and so many others of you. And to Dr. Jean Ayers, whose work set me on this scientific path. To my many collaborators, first and foremost, Dr. Zoe Mayu, who encouraged me to be fearless and stood beside me every step of the way. Thank you, Zoe. To the Children's Specialized Hospital team, where are you? Yay! Donna Kelly, Joanne Hunt, Elke von Hudonk, Gina Freeman, and Patty Fowler, and the team at the Rose F. Kennedy Center at Einstein in the Bronx, Liz Ridgway, Sophie Mulholm, Tim Conley, and John Fox. Thank you for supporting these studies. Thank you to all of my colleagues at the Collaborative Leadership in Ayers Sensory Integration, the Sensory Integration Research Consortium, and the international sensory integration community. Your support and encouragement have sustained me. To the faculty, students, researchers, and clinicians at Jefferson, In particular, those associated with the Jefferson Autism Center of Excellence, who engaged in this work and took it further than I thought possible. A special thank you to all of those who contributed to this presentation by reviewing it, listening to it, zhuzhing it up, and dressing me. And most importantly, to my family, who give me the inspiration and encouragement to do this work. Thank you all. Thank you.